So again, today we're just going to be talking about how we begin to look at cultivating healthy relationships, and it also mean that it is inclusive of sexuality for those for individuals with developmental disabilities. And just for formality, Dr. Ellebeck and I have no disclosures to report. And so as an intro into this discussion, definitely want us to begin to have a discussion about from our own personal views in regards to this topic. So I would ask that in the chat box, can you just describe a couple of terms that you've heard being used to describe sexuality? I'll give you a couple of minutes, and then Nicole will help kind of read off some of those responses. So hooking up. You can say it louder.
Yeah. Nancy from Fort Scott said hooking up.
Okay. Any other?
Oh, Netflix and chill, doing it, sex or yucky stuff.
Okay.
Sandra.
Okay.
And Sydney stated scary.
Scary.
Yeah.
Okay. All right. So what I want us to begin to think about is that I asked the question of describing terms used to describe sexuality. And one of the common responses that we get in terms of this subject is that we actually get responses regarding to the sexual act. Mm-hmm. And so as we get into the discussion regarding this topic, I want to ask you to begin to look at this topic as an overall area of just social health and development and not focus solely on the act of sex. Okay. And so as we start thinking about this subject, one of the things that we want to encourage, oh no, it's not moving forward.
We're going to do this again.
Okay. So some of the things that we're going to look at today, I don't like this camera up there, is really looking about this, gaining knowledge about sexuality, also looking at specific issues as it relates to individuals with developmental disabilities. Dr. Ellebeck will definitely talk about the AAP guidelines regarding contraception, administration, which is one individual participant's particular interest in wanting to get information about. And then we're actually going to explore ways and how do we begin having conversation on this topic. So one of the things I want to say from the start is as we begin to think about sexuality, it is more than intercourse or sex. It's intimacy, it's connection, it's relationships, it's sexual relationships. It's about how we feel about who we are. It's about our gender, it's about our values, and it's about our sexual expression. So when we start thinking about sexuality, it's really the total of who we are, what we believe, what we feel, and how we respond. And so as we think about the topic, we have to be mindful that our own individual values, our own individual upbringing, our own individual experiences have a tendency to, I would say, cloud. I want to use that word. The way in which we may approach the subject with individuals when we're talking about sexuality. So as we start to think about how we support those individuals that have cognitive, intellectual, behavioral impairment, we have to begin to think about how we can best support them so they can, to the best of their abilities, without putting our own values and our own judgments in our response, as well as our supports that we might provide. So we think about the messages, and again, I could have asked in the chat box, and you guys could have come up with a lot of different messages that we know that individuals with developmental disabilities get regarding sexuality, and this is just a few. They shouldn't have sex, right? That's pretty much the overall message across the board. I think a lot of times that we hear, they're not responsible. They don't know how to problem solve. They wouldn't make good parents, and the list could go on and on. But when we think about asking self-advocates, what do you feel that you want to know or learn about sexuality? They want to learn the same things that we want to learn as individuals that are, if we want to say, typically developing or with able-bodied individuals. And then again, they want healthy relationships. They want to be able to have the skills and knowledge to be able to make informed choices. How to choose the right mate. Again, how can they live healthy sexual lives just like as everyone else? So again, as we start to have this discussion, really going to challenge you to think about sexuality is not the actual act of sex. It does encompass that if that's the person's choice. But how do we begin to look at supporting individuals in relation to their sexual health as it ties to their social health? So again, we talked about this as a little bit. One of the, we think about main barriers when it comes to sex education is, again, we feel like we need to protect them. They're fragile. They can't do it. They don't have the ability to do so. So the best thing for us to do is to keep everything away, especially that word called sex, right? But then also we have to realize that also the lack of training and educational resources that actually are available to meet them where they're at, to address their individual developmental and cognitive needs. So again, how are we supporting them? Again, it's a barrier when it comes to those services and supports. But then also we have to think about cultural differences. Also, like I said, our own individual upbringing as it relates to that. And then also we're thinking about our religious beliefs. So a lot of these things cloud our ability to see how social health is also a part of sexual health when it comes to individuals with developmental disabilities. So again, one of the things that I'd like to also bring to the forefront is that we have to think about, the vulnerability. Yes, we know individuals with developmental disabilities are vulnerable in a high-risk population, but we have to also be mindful that preventing them from obtaining the same resources in education and supports as it relates to sexual health also puts them at greater risk. So we think about it that people with developmental and intellectual disabilities are assaulted 7 times higher than those without disabilities, right? And a lot of times it's by people they know. And again, as research shows, again, we have to think about the fact that a lot of times these crimes are not reported. So again, some of the other reasons to support why we need to make sure they have the skills they need to make life choices for themselves. And this just gives a snapshot. Again, we know research is always several years behind. However, the latest research that I was able to find, really just from the Bureau of Justice Statistics, again, just really looking at the prevalence of the violence that individuals with developmental disabilities experience compared to greater society. So again, keep looking in the context not only from a social health aspect, but also physical health when it comes to violent crimes. So as we start to get into this discussion a little bit further, and again, you guys are going to have an opportunity to participate, so I hope you guys are ready for that. We want to begin to think about, as we start thinking about sexuality, right? Not just sex. Then we have to look at the human sexual development continuum. Okay, so as we start thinking about this, one of the things that you'll see as we start to slide is that sex is really the very last step on the continuum, right? So as we start to think about how do we support individuals, there are many ways that we can support individuals with developmental disabilities as it relates to this topic. One of the main ways that we can support individuals in relation to this topic is to provide education that is consistent with their biological age. And I'm going to say that again. We have to provide curriculum, support, conversations, whatever that may encompass in regards to their biological age. So one of the things that we sometimes think about is that, okay, this individual may be 18, but cognitively he is 5. Guess what? His body is 18.
Yeah.
Okay. And so I think that that's where we begin to think about how that's one of the ways we begin to really be a disservice to individuals when we start to talk about subjects in relation to sexual development, is that we want to try to provide the education based on their cognitive ability, which is true. But the focus, again, is really still looking at the biological age of which that person is. Is that okay? I got a couple. Okay. All right. So as we said, coming back to this continuum, again, I'm not going to read everything. We'll definitely share the slides because I want to share time for us to actually have a little engagement this time around. So we think about, again, we're still talking about this continuum, and see at the very bottom of the continuum, it's the actual development of sexual skills. And so how do we begin to look at, there's so many opportunities to support individuals along their growth and development. And so as we think about, again, you know, it has to be based on their biological age. It does not impair their biological developmental needs. And so if that's the one takeaway, I definitely want you guys to definitely kind of put, park on that particular point, is that a person's physical, cognitive, or intellectual impairment does not impair his or her biological developmental needs. So we might be wondering, okay, well, if we start thinking about sexuality really on a continuum and not just a sexual act, here are some things that, you can think of, or here are some areas of interest and concerns just based in several categories. So for instance, young children, okay, we have genital play. We think about reproduction. Where did that come from? Body image. Oh, sorry. Then we start thinking about adolescence. So we know that's the puberties, friendships, sexual expression. Again, some of you guys talked about how you have individuals you work with that wanting those intimate relationships, but don't feel quite like they know how to do it or not mature enough to be able to engage in those activities. Again, sexual orientation, gender identity, masturbation. So again, these taboo subjects that, again, maybe from our own personal experience and upbringing, maybe even uncomfortable for us to address when we think about it. But then if we think about how are we serving and supporting our individuals, how do we set our own values aside in order to best provide the services and support that person we may be providing support to needs. And then just thinking about, since we are talking about transitioning to adulthood, again, I heard someone say that they have individuals they support that have children. Parenting is a reality. So again, body image, divorce, separation, a lot of those things, how do we maintain those relationships? Still, sexual orientation and gender could also be a concern. So again, thinking about the continuum of sexuality, and then also thinking about those things that may be of interest and concern, and how do we provide education awareness regarding those topics. So I'm going to turn it over a little bit to Dr. Elevette.
I think that one of the things that I followed some of my patients now from the times their kids were pretty little until they're adolescents, and there's a fairly high parental fear factor about what's going to happen now that, my child looks like a sexual, is no longer a little girl. She's got sexual development, breast development. And there's concern about a lot of the patients I follow, boys, and sort of what do hormones do with behaviors, and how am I going to manage it when he's asking for things that I think he'll ask for that he shouldn't ask for, but he doesn't really mean anything by it, but it's hard. So starting early with anticipatory guidance, starting not when the child starts their menstrual periods or starts really developing, facial hair for boys is a good idea. So you have time to do education. It's also important to talk about both parental expectations, but also to address the adolescents' expectations for eventually what they want to happen, both with regards to menstruation and then in terms of relationships as well. Some of my parents really want their child to never have a period because again, there's concern about hygiene issues, as well as concern about risk for pregnancy if something were to, the child was to be taken advantage of. But many adolescents actually do really well, and I've been surprised sometimes by children who I would have, or young women especially who I thought would be having a hard time with managing menstrual periods, and they do fine. So the recommendations are not to really start menstrual suppression before you start menses. There are also issues, of course, for contraception. That is something that should be talked about only in the context of figuring out healthy relationships and all of that. There are contraceptive methods that are better than they used to be. We used to do a lot of Depo-Provera for kids who we didn't want them to have menstrual periods. And there are some side effects to that, including weight gain over several years can be in excess of 30 pounds, which is important. And also the risk for decreased bone density. So there are new and better oral contraceptives that really decrease the heaviness of menstrual flow, and that you can use for go to three months at a time before you would do withdrawal bleeding, so the periods are less frequent as well. So some of the birth control pills are really good for that. For girls who don't have developmental disability, the American Academy of Pediatrics and ACOG, the American College of Obstetrics and Gynecology, recommend long-acting reversible contraceptives, such as the IUDs. That often is hard for persons with intellectual and developmental disability. They're nice because they're long-acting. They certainly protect against, they don't protect against STDs, but they do protect against sex if you have a sexually active adolescent, but again, can be challenging in terms of placement for some of our patients. And then I've had a couple families who come in and they said, you know, I don't think that my child really is capable of making a decision, being a parent, having a child. I want something, a hysterectomy or something like that. And there are a lot of ethical implications for non-reversible methods. And really, that needs to be discussed at in sort of a group level with a lot of input from everybody, including the child or young adult. So that is something that is certainly, there's a history of sterilization of people who had intellectual disability as a sort of stain on our history, and we avoid that discussion. So, and there are many good methods for handling both the risk for the messiness of menstruation, and also for pretty good birth control as well. So.
All right, so now we kind of dived in a little bit deep, and we are probably wondering, okay, what do we do now, right? Is everyone still there? Like, what do we do? Mm-hmm. So what we're going to do is really begin to talk about how we can best support those individuals in regards to questions that we may get, we're responding to behaviors that we may see, and really having an opportunity to be able to have some discussion and some practice as it relates to those particular topics. So as we start to think about, you know, how do we begin discussing sexuality? You know, where do we begin? As I said, leave our values out of the discussion, right? We have to take our own personal experiences, our own personal bias, our own personal beliefs, and put them to the side. How do we begin to look through the lens of, if this individual we're supporting, if this is our loved one, and we are wanting them to live their best life and to the fullest of their ability, then their goals, their desire as it relates to sexuality may totally differ from what we feel they're capable of doing. But how do we still support them in reaching that goal? So again, the values in regards to sexuality are entrenched in our society when we start thinking about sex. But as one of the ways in which we are wanting to best support those that we serve is, how do we take the personal out of it and look at it through the lens that we are helping this person live the best life based on their goals and what they want for themselves. And so also want to give positive messages. So if it is yucky to me, that wouldn't be a response that I would want to give. It's just like, wow, that's different. You know, how do we begin to take a step back and again, taking the values out of it? And also remember, we don't have to know all the right, we don't have to know all the answers. This is one subject I think a lot of times that we don't have to deal with when we come to work, because we leave our personal at home, our sexual lives and our sexual aspect of who we are is at home, right? It's not 9 to 5. But when we begin to have discussions with individuals that we serve and we begin to support them, it's a discussion that comes to the table. And so how do we begin to think about, wow, this is taking me in another realm that I may wasn't ready for, but how do I begin to be okay with saying I don't know, right? And it's okay to feel embarrassed, because sex is a topic, again. It's one of those things that we do on our own time, not on the clock, hopefully. All right, and then also, and also it's okay to just say, I'll give you an answer later. You know, it's okay. Sometimes we need a pass. Because we all know we can get questions that, they don't always have to be sex related, but sometimes we can get caught off guard with questions and have to be mindful of, our body language, our response. And sometimes we may just need to pause and be like, you know what, I'm going to get back to you, right? So that we can maybe go regroup, figure out what we want to say, and maybe come back to the table. But that's okay. Also remembering we want to give facts, but also be concrete, using repetition. And also when I go back to being concrete, it's our opportunity to increase awareness, understanding in relation to this topic. And one way we do that is using anatomically correct language. So we're not going to say private parts. We're going to say a penis or a vagina. Oh, wow, that's kind of different coming out of our mouths because we're talking about it at work, right? But again, we're supporting an individual, and the best way to support them is making sure that we're providing them with correct information, right? All right, and then also want to ask individuals, is there someone else that you may have in your circle that you feel you can trust or talk to ask about questions in regards to sexuality? Because again, you don't want to be their sole source of information, but how do they begin to use other resources or begin to practice the skill of developing relationships? So all of this is all about that social development as well. So thinking about the different types of questions that usually come up in this topic is things like that are based on facts. So how to, where do babies come from? How are they made? And also values. Should I have sex? Or your opinion, what contraception should I use? But then also thinking about the personal, you get some of those questions too. And this is not just from individuals with, let me just make this point. This is not just from individuals with developmental disabilities. This is from all individuals, right? So how can we best support them in that way? So again, as we start to think about it, leaving our values at the door. So when answering questions, these are just some we say a teachable format, because again, what we want to do in anyone we're talking young person or young adult that we're working with is how are we increasing their understanding of the subject or topic, right? So again, there's no right or wrong answer. There's no good or bad question. It's great that you're even asking. You want to figure out what are they really thinking or asking. But then we also have to take time, a pause, to decide what message we want to give. And remembering to use correct vocabulary, not slang, and then also asking for feedback in that process. So for instance, if we had a question related to information, what is birth control? You could just keep it simple. There's a lot of different types of birth control. We don't want to say there's just one. We're increasing understanding. And what is it that they do? They help people not get pregnant when they have vaginal sex, right? So that person can say, what is vaginal? All right, that begins to open up another question, right? But again, you see how, I'm not saying that this couldn't create an hour-long discussion, but do you see how it's just simple, straight, factual information, and you're increasing awareness and understanding? Another question could be, do you think it's okay to have sex before you're married? Wow. So really what they're wanting to know is, what do you feel? What should I do? They're trying to make a decision, right? But this is an opportunity for you to ask, well, what do you think? What's important to you? Because you're helping to guide and shape their understanding versus giving your opinion as to how you feel they should live their lives. So it also engages and draws them back into the discussion, and you can get a better understanding of what it is that they're really trying to ask. And then the other question is also, they get personal, how often do you have sex? So as a short activity, I want to ask you guys to answer two questions. When is it okay to answer this question, and how would you answer the question?
Chatting in.
We get some responses. No responses?
I wouldn't put the name, I would just say, okay.
Someone stated it depends on both people making that decision.
Okay. All right. So when thinking about this question, any other one come in?
Someone said some people.
Okay. All right. So I would say that the question would be, oh, that's a great question. Why do you ask? Is it something that you're interested about? because you don't want to give your own personal, again, remember we said we're keeping the personal out of the conversation. You want to use this as an opportunity to get a better understanding of what it is that they're asking. So it is never, I would say, okay to answer this question. You want to take it as an opportunity to better understand what it is that the person is asking, so you can better provide the best answer for them in that situation. All right? All right, so here's another method of answering questions too. And this is really helpful when individuals are asking about a specific concept or a specific activity, right? So again, it really brings in what is the physical aspect. What is it? You know, socially, how is it used? So you think of, is it private? Is it in public setting? Are there laws around it? You know, does it relate to someone being responsible? And then also tying it back to the emotional aspect of what is the emotional connection or feeling associated with the activity? So again, we're still in answering questions. We want to make sure we're giving accurate information, creating a safe environment for learning, and making sure it's age appropriate, right? So here's an example. What is a condom? So it's a rubber sock that covers a man's penis. It's used in private and it protects you and your partner. You know, you can say from pregnancy, if you wanted to add from pregnancy and other sexually transmitted diseases if you wanted to. And many people feel good when they use them because they're being responsible. Simple way of just sticking to the facts. So again, a lot of times we think of when we start talking about sex with young people, we really get kind of nervous because it's like, are we teeter-tottering on that era of we can't talk about sex? You know, we're going to get in trouble if we're in a school setting because we're talking about these things. But one of the things is we're just providing facts. If we're just providing facts, it's just like if someone was asking you an answer to a math problem. I provided you with the facts. I didn't say, yes, go do it. I just provided you factual information regarding a particular question, and then also asking you to explore and be able to get greater understanding of what it is that you want to know about that subject, right? So as we start talking about assessing, and I'm kind of move a little bit faster so we have time for case discussion. When we think about assessing questions, there is a theory of counterfeit deviance developed by David Hinsberger. And it really looks at how sometimes, and I'll go into this, these are different categories that he's listed that sometimes sexual behavior, some of the reasons why a person's behavior may be seen as sexual. This is a better way to explain it. And so what I want to see, and all this information will be included in the resources for the presentation. So really getting into this whole theory is that really is thinking about how sometimes behaviors are deemed deviant upon initial observation, right? And so this theory really challenges us to think about it, regardless of the level of the intrusive behaviors, they're not always a result of deviant arousal. And that we must, yes, take sexual misbehavior seriously, but we should not make those assumptions. And that this theory can be extended to any activities, any criminal activities that may have been committed by a person with developmental disabilities. And to really truly understand the meaning behind the behavior, we need to consider medical, psychiatric, psychological, habilitative, social, and environmental factors that could have influenced that behavior. So again, how do we assess it? That's what we're talking about. So this is an example real quick, and for time's sake, I'm going to go through the activity, is that a woman with a developmental disability is using a pencil to masturbate and is hurting herself. Can anybody just chime in and see what they might feel could be a potential reason why this person may be doing that, and what could be a potential response to that behavior? Any thoughts? Would you guys prefer to talk rather than type? Feel free to unmute if you want to jump in. I know it's kind of an uncomfortable conversation.
Someone says not given appropriate appliances.
Okay. All right. So thinking about, again, these are just some of the things. Could it be she may be sexually aroused? Again, she's a human. So we have to start thinking about, again, how do we come from the negative always in regards to looking at trying to understand sexual behavior? Could it be discomfort? Could she be modeling something that she saw on TV? So again, as I go back to these different categories, each of these categories could definitely, again, in this theory, explain some of the reasonings behind behaviors to better understand how we can better support them, right? So we think about this sexual arousal. Maybe she needs sexual education, right? Maybe she does need to go get sexual toys to be able to satisfy that urge, right? Is she entitled to that? As a human, she is. That maybe that's a conversation that she has to have with her guardian or loved one. But how do we support her? If there's discomfort or if she's modeling. So again, how do we begin to look at the behavior before we jump to that assumption?
People shared as well that may have been told in the past that masturbation was bad, or past abuse could lead to this as well.
Okay.
Can you repeat that?
Past abuse could lead to this as
Oh,
well.
past abuse.
All right. So all of these things, again, and you're just trying to get an understanding. You're just saying, what if? What could be going on? Right? That's what you're trying to do. And then now we're going to look at, well, how do we respond? So one of the things is we have to think about is first, should we just ignore it? Right? Or not? And if we are going to address it, then we need to name the behavior. We shouldn't say, hey, we saw you in there, playing with a pencil. Okay, she could have been writing her name on a notebook, and that's what her mind goes to. But we have to really be descriptive of what we saw. Hey, Sally, I saw that you were, putting that pencil in your vagina, right? Sounds a little uncomfortable, a little bit, I'm sure. But again, how do we begin to this is a subject that does make us uncomfortable because, again, we're talking about a very personal subject, but how do we still support those that need us the most, right? And then, again, trying to understand what is the meaning behind behind the behavior, and then how do we go from there? Those are the ways in which we're looking at how do we respond.
And so often it is a knowledge deficit because it is such a taboo topic that people talk about it in these very abstract terms, which we know are kids with autism or, adolescents and adults and other developmental disabilities. Abstract things are so hard for them, and people are already talking about this, thing in very abstract terms, and people aren't, breaking it down into a concrete, understandable way. And so there's just all this confusion, and it just makes sense why there would be so many opportunities for people, interpreting things the wrong way, or whether it's the individual or people around them, or yeah.
And to add to that, someone stated, I think if we struggle with addressing it and showing that we are uncomfortable, it shows to the individual that there is something wrong, that it's not natural.
Right, absolutely.
And I think that's where, again, taking that time out. I think one of the things, again, is it is, if you need to take a time out or tap out and be, to have someone else that may be a better fit to address that, because again, we have to be aware of our own comfort level. So again, if we're noticing that our values are coming to the forefront, and again, it's all, again, through practice. This is not something that happens overnight, but we may need to tap out. Hey, Dr. Ellebeck, Sally was in the room, doing it with the pencil, right? I'm saying doing it because, again, I'm saying doing it with the pencil. And so do you think that you would be better able to have a conversation, because again, you don't want to send the negative message. What you want to do is to try to understand the behavior to better support. Again, maybe it's not even sexual arousal. Maybe it's discomfort. Maybe it's a medical condition. Maybe, medication is, causing her to have some discomfort. So all those things, like we said, instead of jumping immediately to an assumption that is sexually deviant of some sort, how do we begin to look at it from a standpoint of, let me try to better understand it so that I can have the best approach? And to better understand it, we have to bring that person into the conversation. All right. And going back to the sexual deviant piece, before we wrap up and do a case study, just want to say we have to really be mindful of how we really start supporting individuals in this regard, because when we think about the number of individuals with developmental disabilities that have been labeled as sexual predators or have these records,
Or in jail.
or all these negative effects and consequences because their behavior has been viewed criminally. And so again, if we are being mindful and increasing our awareness and understanding of really probing and trying to get a better understanding of what's really going on, I think that the number of those individuals could significantly decrease. So I'm gonna jump past this because I did talk through that example before. All right. So just want to wrap it up so we do have at least time, kind of went over time for our case study. Just want to just say again, remembering that sexuality is more than just the act of sex. It's the sum of a person's total being. And that, you know, just as able-bodied individuals of all abilities, sex education has to be based on their biological age. And then also just thinking again, reframing from imposing our values on individuals that we support in regards to sexuality. I think one of the things that we have to think about is that mental health, physical health, social health, and sexual health are all important for overall health and quality of life. And I think that if we start to look at sexuality and the act of sex as a part of social health, we can have a greater impact on those that we serve. So again, sexual health matters because sexual health is social health.